Hi everyone, welcome to my channel. My name is Hector Garcia and I'm a doctor. In this video, I made a really concise crash course of the clinical applications of ultrasound. I cover pediatrics, OBGYN, GI and GU system, vascular, and much more. I added timestamps in the video description below to help you navigate so you can focus on what you need. If this video helps you, please subscribe, smash the like button, and let me know in the comment section below any question you may have. This video is for educational purposes only and not for clinical making decisions. Stay tuned. I'm just gonna cover real quick the understanding principles of ultrasound. So for ultrasound, there are like three major components to produce like sonographic images: the production of high frequency sound waves, and then the reception of a reflected wave or echo, and then that echo is converted into an actual image. And then here on the right, we have like, if it goes through a bone, then almost everything is going to be reflected back, and you're gonna see very, very bright. And then if it's going through the liver, it's kind of like mid absorption. And then versus if it goes through a cyst, where it's going to be pretty much everything is gonna go through. And ultrasound kind of works the same way as a bat trying to locate the prey. It sends the echo and then comes back. So in ultrasound, just to get the keywords down, we have echogenicity, which is the brightness or darkness of a tissue on ultrasound. And then if it reflects more echoes, as in this case, like a bone, something calcium, or a metal, most of it is going to be returned back, and you're going to get either echogenic or hyperechoic. Then if it transmits more echoes, then think of it like a cyst is going to get darker because there are no too many echoes getting back to the transducer, and it's going to be either, we call it sonolucent or hypoechoic. And some of it. And then the last one is that if it transmits all the echoes, then we call that anechoic. And you can kind of see in this image on the right, hyperechoic side, very bright, think like a bone, and then anechoic, kind of like a cyst, it will be black. And then in the imaging plane, just to kind of get the terminology down, every time we're going to read an ultrasound image, in the left, if it's in the sagittal plane, in the left is going to be cranial, in the right is going to be the caudal toward the feet, kind of like in the same way I have this man over here. And then the top is going to be superficial or anterior, and then the bottom is going to be posterior. And then if we are in the transverse plane, we kind of read it like the same as a chest x-ray. In the left is going to be the right, the patient's right, or the probe is going to be pointing to the patient's right. And then our left or our right is going to be pointing to the patient's left. So it's kind of like the same way of reading a chest x-ray. And then for the frequencies, we have different, like high frequencies is going to be like higher resolutions or more details, but you get like shorter penetration, and it's more for superficial structures. And if you use like a lower frequency transducers, it's going to be for deep structures, but then the resolution kind of decreases or diminishes. And then these are the different types of transducers that we use in ultrasound. Now, these are the different kinds of ultrasound. Just to give you an idea, the A mode is mostly used in ophthalmology. The B mode is more for the kind of like the black and white. And then the M mode is for motion. Doppler is for vascular study. And then duplex is M mode plus Doppler. This is kind of to show the different types of ultrasound. Then the advantages, obviously, of ultrasound: no ionizing radiation, no long-term side effects. The images are in real time, and pretty much is no harm to the patient. And then the disadvantages is like difficulty penetrating through bone. And then it is depends on the skills of the operator. And then it may be difficult for obese patient to actually look at deeper structures. And then, so let's go to the fun part, to what is like clinically relevant. And this is where I'm going to really combine it with a lot of like a step 1 and a step 2. That was my goal here. So the first one that we're going to go is everything about the biliary tree. So let's just get the normal anatomy down. This is the gallbladder, which is like a pouch. And then toward the in this image, in the right, we have the head of the patient toward the head, and then the left is where the feet, anterior, posterior. This is the gallbladder. This is the arrow is pointing to the gallbladder wall. And then here on the right, we have the common bile duct, which is lateral, which is this white arrow is pointing to the hepatic artery, is lateral to the hepatic artery and anterior to the portal vein. And this is the IVC. And this is kind of like a picture representation. So on this one, let's assume that we see something echogenic material within the gallbladder. So what are some of the diagnoses that come to mind? Gallstone. And for that, we see that it's mobile and shadowing. And I will explain in the next picture what I mean by that. And if it's a gallbladder sludge, it's going to be mobile, but non-shadowing. And then we have a gallbladder polyp, and then a hyperplastic cholecystosis, which just means multiple polyps. So here I have the 4 diagnoses for a gallstone. So it's going to be mobile, because if you move the patient, then the stone is going to go to the most dependent region of the gallbladder. And then shadowing, because it produces what is called a posterior acoustical shadowing, meaning that you have echogenic material or very bright, and then behind the gallstones, you're going to see this darkness. Here only we have a 1 gallstones, and then you can also see in the image below multiple gallstones. Now a polyp, the difference between a polyp and a gallstones is that the polyp does not produce acoustical shadow, and is usually non-mobile. It is non-mobile and produces no acoustical shadow. And then a gallbladder sludge, I think of this like honey in the gallbladder, kind of like honey. Obviously it's not honey, but kind of like the consistency. So we're going to see is mobile. This sludge is kind of mobile. And then behind, we're not going to see a post-acoustical shadow, because in the gallstone, we do see that. In the sludge, we don't. And then in the hyperplastic cholecystosis, it's like multiple polyps, kind of like in these second images here, is a multiple polyps. And again, is non-mobile and does not produce acoustical shadowing, and it's kind of like attached. It may be vascular sometime, it may be attached to the gallbladder. Now, the first diagnosis that we're going to cover is acute cholecystitis, and for this, the presentation for this would be kind of like fever, right upper quadrant pain, and fever, right upper quadrant pain. And then in ultrasound, we're going to see a thickening of the gallbladder, which is like where these arrows are showing, thickening of the gallbladder. Then we're also going to see a distended gallbladder. And in the second images, we're also going to see sometimes a pericholecystic fluid over here. This is the dash arrow showing to a pericholecystic fluid. So if you see like patient with this in the presentation of fever, right upper quadrant pain, and leukocytosis, because it's itis, which means that there is inflammation, then this is acute calculous cholecystitis. And if you see a gallstones, then that's what we mean by calculus. Now, complication of acute cholecystitis, we see emphysematous cholecystitis. That's the first one, which means gas in the gallbladder. Now, gas sometimes in ultrasound is seen as this like rays in here. And it shows like very hyperechoic kind of reticular rays in the gallbladder. This is emphysematous cholecystitis. It is a surgical emergency. Then the other one complication of acute cholecystitis is gangrenous cholecystitis, which means necrosis of the gallbladder, and it produces layering or like a sloughing of the membranes of the gallbladder, as we can see here with this yellow arrow. Then in the third one, another complication could be gallbladder perforation, which is a focal perforation or discontinuation of the gallbladder wall, as we can see in this arrow. And all of these are surgical emergencies. Now, acalculous cholecystitis is pretty much the same as acute cholecystitis. It just there is no gallstones, and it's present mostly in very sick patients in the ICU who have been in prolonged TPN, meaning that the gallbladder has not been used or have been relieving their materials. And people who are in the ICU, and then the similar is in appearance to acute cholecystitis, but just without stones. And then for exams, the right answer for the treatment is going to be cholecystostomy for initial drainage. And they sometimes put the two of them, cholecystectomy and cholecystostomy. So the right answer is cholecystostomy because the patient cannot undergo surgery because it's like in the ICU, it's like very chronic condition. So it's not candidate for surgery. So we put like a tube, we drain the gallbladder, and that's the solution. Now, the next one is a porcelain gallbladder, and we can see kind of this calcification of the all around the gallbladder for this. And then the next best step in management, which they usually ask in exams, is going to be prophylactic cholecystectomy, meaning you remove the gallbladder because of the high risk of going into a malignancy like a gallbladder carcinoma. So we take it prophylactically. Now, other diagnoses for an echogenic gallbladder, in addition to porcelain gallbladder that we should have in mind, are gallbladder packed full of stones and emphysematous cholecystitis that I talked about. Now, the next one is a Courvoisier gallbladder. Hopefully I'm saying it right. And this is a markedly distended gallbladder. It's an enlarged palpable gallbladder. You're going to see jaundice, but it is not painful. And this is because of a possible malignancy. And one of the interesting things is when the gallbladder is distended, this cannot be due to a stone, because if it were due to a stone, then it will have a Murphy sign in acute cholecystitis, but this is not the case here. The gallbladder is palpable, you can palpate it, and the patient does not feel the pain. Usually due to a tumor, could be arising from the common bile duct or the pancreatic or periampullary. So the next one is a Mirizzi syndrome. It's sometimes it shows up on exams. I remember seeing this in New World, but the way that I think about this is an acute cholecystitis plus jaundice. And one of the things is that acute cholecystitis, like I said before, is when the stone gets lodged in the cystic duct, but does not cause this does not cause jaundice. But if it were to cause jaundice, then that would be Mirizzi syndrome, and it's because the stone compresses. So it blocks the cystic duct, but at the same time compresses the hepatic duct. And by compressing the hepatic duct, that there causes jaundice. And usually for exams, what they look for is like, what is a possible complication of this is a cholecysto, meaning a fistula between the cystic duct and the common bile duct. And anytime you block the common bile duct, you get jaundice. So that's why they always, every time they test this condition in UWorld, the right answer is going to be for a complication, cholecystocholedochal fistula. And then in the ultrasound image, we see kind of like the stone lodged in the cystic duct, and it's going to, and the cystic duct is kind of compressing the common bile duct. Now, the other one is the primary gallbladder carcinoma. And for this, the clinical presentation is like someone who is kind of old, elderly, right upper quadrant pain, weight loss, jaundice, and it may have some of the risk factor for chronic cholecystitis, porcelain gallbladder, which porcelain gallbladder forms due to like repeated inflammation of the gallbladder, like PSC, like primary sclerosing cholangitis, IBD, especially UC, because ulcerative colitis. And then if you have multiple polyps, which can turn into can be cancerous. If they are too big, the risk for cancer increases. Now, the next one I want to cover is the bile duct anatomy. This is a common bile duct, and this is the right hepatic artery in the portal vein. The common bile duct, especially in radiology, we have to know that it's lateral to the hepatic artery and anterior to the common bile duct. And the normal size for the common bile duct is less than 6 millimeters before the age of 60. After the age of 60, 1 millimeter larger is normal. So for example, someone who is 80 years old with an 8 millimeter common bile duct, it is within the range of normal. And right here in the picture, I want to represent the next diagnosis of choledocholithiasis. And here we see a stone, again, what I mentioned previously, We see echogenic material is very bright, hyperechoic, and we see this posterior acoustical shadowing, meaning this like shadow behind the stone, and that's because the echo cannot go through the stone. So it leaves this imaging artifact that actually is very pathognomonic for stones. And this is a quick recap of all the biliary pathologies. If it's a polyp, non-mobile, non-shadowing ultrasound. Sludge, mobile and non-shadowing. Cholecystoses is more like the patient usually presents for exams with colicky pain after fatty foods. And when you do an ultrasound, you're going to see a stone. It is dependent. It is like a position dependent because the stone is mobile and shadowing. And then if it's acute cholecystitis, is the itis meaning inflammation. So you're going to see fever and leukocytosis. Fever, leukocytosis indicates inflammation. And then the pain is going to be constant, not coming and going like cholecystoses, but constant. And then we talked about before the complications of cholecystitis. These three. The next one is choledocholithiasis, and that's when the stone get lodged in the common bile duct, and the common bile duct increases greater than 6 millimeter. Now, anything that increases the common bile duct, anything that get lodged in the common bile duct causes jaundice. So that's why choledocholithiasis causes jaundice, but does not cause inflammation. So there is no fever and there is no jaundice. That's one of the reasons to differentiate it. Now, ascending cholangitis is pretty much like a step up in choledocholithiasis, meaning a stone get lodged in the common bile duct, but then that stone started producing infection. And the reason is ascending is because when it get lodged in the common bile duct, the bacteria, it's an itis for bacteria, which ascends the biliary tree. And you can get the Charcot's triad, again, fever, right upper quadrant pain, because in leukocytosis and jaundice. Itis means inflammation, fever, and leukocytosis. And then there is going to be also jaundice because there is the common bile duct is obstructed. And then it can progress to something called renal spentat, where there is hypotension and altered mental status, and that means that the patient is going to go into shock. So ERCP, emergent ERCP, is the right treatment for that. Now, acalculous cholecystitis, this is in hospital ICU person, long-term TPN, and the answer for board exams is going to be cholecystostomy. Porcelain gallbladder, person with chronic inflammation of the gallbladder for multiple years has been having multiple bouts of acute cholecystitis. So the right answer for this on exam is prophylactic cholecystectomy. And then the Courvoisier gallbladder, that's usually due to malignancy, is the enlarged palpable gallbladder. There is jaundice and it's not painful. And this is because it's not due to a stone. This is not due to a stone. And then the Mirizzi Syndrome, which we talked about it, is the acute cholecystitis plus jaundice in this case. And jaundice because we are blocking the common bile duct. And then the board answer for this is a complication will be a cholecystocholidoco fistula. Yes, it's a fistula between the cystic duct and the common bile duct. That's the UWorld answer for that. And then the primary gallbladder carcinoma, old person with right upper quadrant pain, jaundice, weight loss. And then if there are some risk factors such as Middle East, then cholangiocarcinoma could be an answer as well. Now let's move on. For the liver, so the normal is that in the liver is the same echogenicity as the kidney parenchyma. And this is the renal cortex of the kidney, which is very hyperechoic, whereas the kidney parenchyma is the same echogenicity as the liver. So that is normal. Now in hepatic steatosis, the liver gets very fatty. And then the fat in ultrasound becomes more hyperechoic, brighter. In layman's term, it becomes brighter. So this is abnormal because the liver becomes much brighter than the renal parenchyma. Right here. And the reason the kidney, because this is the kidney, this is the renal sinus, what is in white. The reason the renal sinus is white is because the fat surrounding the renal sinus, that is because it's blood. Okay. So just remember that in hepatic steatosis, the takeaway point is hepatic steatosis, the liver becomes hyperechoic, more hyperechoic or brighter than the renal parenchyma. Now this is cirrhosis, and I put the three of them: the normal, the fatty, and then the cirrhosis. Which in right here we see kind of in cirrhosis, the liver gets very nodular, shrunken, and you can kind of see this nodular appearance of the liver. Okay, so in hepatic metastasis, here in the liver, we start seeing these kind of like these balls and metastatic lesions in ultrasound. Okay, and then the abdominal hernia, we have the most common type of the most common location is in the inguinal region, and this is what it is in ultrasound. So here we have that when the patient is asked to cough, the hernia gets kind of like a stuck. We can kind of see it on the image, and for that we have the indirect inguinal hernia and the direct. The indirect is usually in indirect infant, and then usually if it's like someone who presents with a hydrocele, then they're gonna ask what is the pathophysiology for this, and then is failure of the processes vaginalis to close. That is like the U-world answer: failure of the processes vaginalis in indirect hernia. In a direct hernia, is usually in older people, and they ask what is the pathophysiology. Is acquired weakness of the transverse fascia, And then the other type of hernia is the femoral hernia, femur in female, and they have a high risk of strangulation. If a strangulation happens, that is a surgical emergency. Okay, and then something that they usually like to test, I know by the mnemonic, MDs don't lie. MDs meaning, I remember for medial, that is middle, the direct hernia is medial to the inferior epigastric vessel. Direct hernia, middle to the inferior epigastric vessel. And the MDs don't lie for lateral, for indirect hernia is lateral to the inferior epigastric vessel. That is the other piece of information for exams. Now, this is the acute appendicitis, obviously is with ultrasound, and I'm gonna play it. And we can kind of see that it's due to a stone lodged in the ileocecal valve. And the reason it is a stone, again, what happened? Okay, the reason it is a stone is because we can kind of see echogenic material where when the blue arrow appears, we'll see, okay, there, echogenic material, and then we see posterior acoustic shadowing, this shadow behind the stone. And we know that is a stone because echoes cannot get through. So that is a acute appendicitis there. How it presents, usually a periumbilical pain that moves to the right lower quadrant in a patient over days, and it's very acute. And then once we know it's appendicitis, surgery for that. Now, the next one, we're gonna cover a GU system, the kidney, bladders, uterus, testicle, uterus. So we're gonna start with the kidney. So the kidney, the renal parenchyma, as I said before, is the same echogenicity as the liver, and then the renal sinus is wider or brighter because it is surrounded by fat. And these are the dimensions of the kidney. Now, one of the pathologies with the kidney is hydronephrosis. Let's assume there is like a stone lodged in the ureter. Then that is the backside of urine, and then we get the calyces, and the kidney and the pelvis gets very compressed by urine, and it looks much wider. And then in the image on the right, we see the lack of blood flow, and this indicates, all of this indicates that is urine. This anechoic or black area or anechoic fluid indicates urine. Now, this is renal cell carcinoma. Remember, renal cell carcinoma, the presentation for this is hematuria, flame pain, and palpable mass. Hematuria, flame pain, palpable mass usually presents in about 10% of the cases, but for exam, it's like a pretty good indicator. Now, the association that we have to know with that is VHL, like von Hippel-Lindau chromosome 3, and this is that presents with hemangioblastoma of the eyes, hemangioblastoma of the brain. If you see someone with hemangioblastoma and on top of that flank pain, that is renal cell carcinoma, and if the biggest risk factor for renal cell carcinoma is smoking, so if there is smoking in the answer, plus someone with a hemangioblastoma of the brain or eyes, and a flank pain or hematuria, that is renal cell carcinoma. And I'm going to play here. This is ultrasound, and we're using micro bubbles here, and we can kind of see that this is a mass in the kidney. And with the clinical presentation that I said before, then that is indicative of renal cell carcinoma. And other association for renal cell carcinoma would be the PTHRP, the PTH-related peptide. We also have ACTH and polycythemia. Those are important association for exams. Now, this is the bladder. So this is the anatomy of the bladder. And this is in this image, we have the bladder, the uterus, because this is a female. And then this is a male. We have the bladder, the prostate, the rectum. And when we're placing the probe, one of the things that we have to make sure is that we kind of angle the probe from from the belly down, or more toward the feet, because if we go too low, then we might hit the pubic bone. And all the echo, you're not gonna see anything because all the waves are going to hit the pubic bone, and you're not gonna see below anything below. So you have to kind of angle the transducer to catch the bladder and kind of avoid hitting the pubic bone. Now, things important is the bladder tumor. So for bladder tumor, the way this is described this on exam is like irregular lining of the bladder with an increased vascularity. And the reason they put increased vascularity is because they want to kind of draw you away from debris or blood clot. Tumors do get blood vessels that feed the tumor. So that's why you see in this image, this red, this is kind of blood flow. And this is kind of like an irregularity of the lining of the gallbladder, of the bladder. And this indicates a tumor. Now, important things for exam, test it over and over. What is the risk factor for bladder cancer? The risk factors are smoking is one, cyclophosphamide, ifosfamide, aniline dyes. So the way they present, and schistosoma hematobium, that's the other, schistosoma hematobium. So the way they present this on exam is like, I don't know, like 50-year-old female who have been hairdresser for many years, also a smoker, and right now presents with hematuria, painless hematuria. Hairdressers, they many products in hairdress, they use aniline dyes. So that's one exposure for many years. And if she has been smoking, that's a second exposure. And then now she's presenting with painless hematuria. That is a huge indication for bladder tumor. The other way they can present this on exam is maybe like a 6-year-old person with a lymphoma who has been taking medications for many years. And maybe this person is also a smoker for many years. First of all, lymphoma and treated with medication, obviously the MBM is not going to tell you which medication, but you should be thinking cyclophosphamide, ifosfamide. And now a smoker for many years and painless hematuria, huge indication for bladder tumor. And the other presentation of bladder cancer is someone from the Middle East that present with painless hematuria that's due to schistosoma hematobium. Of all high-yield presentation. Now, the other high-yield presentation is kind of like in children, and that kind of seem, or kind of maybe 1 year of age, that seem to have like painless hematuria. And if you're suspecting bladder tumor, it is an adenocarcinoma of the bladder, and that's because failure of the urachus to involute. That is a pathophysiology behind it. It is not as high yield, but sometimes it makes its way to exams. Failure of the urachus to involute give rise to an adenocarcinoma of the bladder. Whereas in the previous one, they lead to a squamous cell carcinoma of the bladder. All of the smoking, aniline dye, cyclophosphamide, ifosfamide, and schistosome hematobia, and they all lead to an squamous cell carcinoma of the bladder. Okay, moving on. Here, so this is the testicular ultrasound anatomy. So we got the anterior, posterior here, cranial towards the patient head and caudal, and this is the transversal image. And then for the testicles, what we have to know is testicular torsion, which is a medical emergency. In this case, the right testicle, we see blood flow, whereas in the left testicle, which is this one, we don't see any blood flow. That is a surgical emergency, and it is diagnosed with ultrasound. Now, other things that we have to think in our differential for acute scrotal pain include testicular torsion, epididymitis, orchitis, testicular trauma, and herniation of bowel contents into the scrotum. Now, sometimes the NBME, what they try to do is like they're very non-specific between testicular torsion and epididymitis. So they kind of give you these non-specific subtle presentation, and then they tell you what is the best next step in management. And the next best step is going to be to do an ultrasound for this one. Maybe they have some acute scrotal pain. This patient has high-risk sexual behavior, which is more for epididymitis, and this has been developed slowly. So you're kind of like in between testicular torsion and epididymitis, and they ask you, what is the next best step in management? Is do a scrotal ultrasound. Now, other high-yield things is that for bugs, if it's below 35, if the patient is below 35, the most common bugs are chlamydia and gonorrhea. If the patient is above 35 years old, the most common bug is orchitis. Okay, and I think that one, okay. And then if it's herniation of abdominal contents into the scrotum, that could perfectly be an indirect hernia, and it's because of failure of the processes vaginalis to develop the failure of the processes vaginalis, where bowel gets into the scrotum. Okay. Now for female, here we have the uterine anatomy, and there are three types of normal uterus positions. The first, and we describe it versus the vagina with respect to the cervix. We say that version, and then the cervix with respect to the uterine body, we call the flexion. For example, antevere means that the with respect to the vagina, the cervix is kind of laying anteriorly, and then the flexion meaning that with respect to the uterine body with respect to the cervix is kind of laying posteriorly. So this is not as high yield, but just something to know. And then in the image on the right, this is the uterus, and this thing, it looks like a sandwich. This thing in the middle is the endometrium, which is kind of like the endometrial lining. It's like echogenic or brighter. And then we're going to start seeing some of the pathologies here. So first of all, fibroids. Usually these are, the way this presents is with female who feel like pain, like pelvic pain, heaviness. And when they go to the physician, the OBGYN physician, when they palpate, they note some irregularities in the irregularities in the abdomen or in the pelvic region. Better say it's a pelvic region. So this is a possible afibroma. Sometimes they may have dysmenorrhea and all of that. And this is a representation of the common types. Intramural is the most common type of fibroid. And then subserosal, submucosal tend to cause a lot of bleeding because they are at the edge. They tend to cause a lot of bleeding. And then pedunculated. Now, if the MBME throws a question with kind of like very non-specific, and you're like, yeah, I think this is a fibroid, but I'm not sure which one, then go with intramural because this is the most common presentation. Now, for in B, we have the intramural because it's between myometrium, as we can see with the white arrow. The white arrows are joined to the myometrium. And then these fibroids can sometimes, they grow bigger than their supply, so they may necrose and calcify. So they start getting necrosed and wider. And you can see kind of some of this calcification on ultrasound. Now, on this one, on image C, we see a submucosal and it's kind of like splitting the uterus right here, is submucosal. And then in this one, we have seen a subserosal, because this is the uterus over here, and this is kind of like at the edge. It's not surrounded by myometrium, because the myometrium kind of ends. The white arrow is pointing kind of like to the very end of the uterus. So it's like, this is subserosal. Okay. Now, adenomyosis, it's pretty much when endometrium products get deep into the uterus. And then the uterus becomes very globular and bulgy. And when you palpate it, this is the key word: uniformly enlarged uterus. Uniformly enlarged uterus. That's a key word for exam. And then the reason, and that's how you can differentiate it from fibroid, because fibroid, they're irregular. This is uniformly enlarged. And there is going to be a lot of bleeding. Now, the definitive diagnosis for this, it is a hysterectomy. That is a usually exam answer right there. Okay, moving on. Then the normal ovarian anatomy, ultrasound, and this is the size of the ultrasound, 2, 3, 4. And this the ultrasound with a few cysts right there. Okay. And then here we see a follicle before it ruptured, and then minutes later how the follicle ruptured, and the black arrow right here is pointing to a free fluid. This is a follicle. Okay, now this is an ovarian cyst, like a simple cyst, and we see all black. What we were explaining at the very beginning, all the echoes go through, is everything black, versus this one is hemorrhagic, and we see lacy reticular, hyperechoic, kind of linear appearances. That indicates that it's hemorrhagic, this ovarian cyst. And then PCOS. This is like usually the female, the presentation would be like an obese female with kind of like hair in the chin, hair in areas where men usually have hair. And then when you see an ultrasound, you see multiple cysts, as we can see here. This is the ovary, multiple cysts. That is PCOS. Another name for PCOS is Steinlenthal syndrome. Steinlenthal syndrome. And then here we have a dermoid cyst. Dermoid cysts contain all three layers of ectoderm, endoderm, and mesoderm, and like hair tissue. And they are very heterogeneously echogenic, meaning that they are composed of multiple things, of multiple tissues. So they tend to, when they are in the ovaries, they tend to make the ovary torsed or torsion. So these are likely for, increases the risk for ovarian torsion, this ovarian dermoid cyst. And then we'll see in the next one, ovarian tumor. This is an endometrioma. This one on the left is an endometrioma, which is what we call a chocolate cyst, and is a finding in endometriosis. An endometrioma is a chocolate cyst. Is a brown blood cyst. Now this one on the right, it is also a cyst, but it's malignant, and it is pointing some nodular papillary projections. So if in the exam they say something like nodular papillary projection, which is as in this case, then that is highly subjective of a malignant cyst. And other malignant feature would be spiculated, thickening wall. That's another one. Okay. Now, the next one is ovarian torsion, which is a surgical emergency. And this is what I was describing earlier, a dermoid cyst that caused the uterus to undergo torsion. And this is extremely painful in female. It's like a young female. She's probably, in an exam, the way I've seen it, it's like she's doing yoga or studying, and then she have this sudden pain in the abdomen. Ovarian torsion is one of the top one, and they usually try to confuse you with acute appendicitis or ectopic pregnancy. That's the differential diagnosis for this. Okay, and then surgical emergency, straight to the OR. And we can also do a Doppler and see if there is blood flow. If there is no blood flow, this is ovarian torsion. And if there is, but we still have a lot of suspicion for ovarian torsion, then a Doppler does not. Blood flow in Doppler does not rule out ovarian torsion. High yield. Okay. Now this is a pelvic inflammatory disease. This is a fallopian tube here, and then this is a transfer view, and we can see that there is a lot of debris. And in the transfer view, the fallopian tube has been kind of like undergoing some type of like torsion, is dilated, tortuous, and a lot of debris. Usually, this is in female with high risk sexual behavior, and the top bug that can cause this is chlamydia or gonorrhea that has been untreated or not fully treated. Sometimes they said, oh, years ago she had this pelvic infection that she only take metronidazole for a few days, and then she didn't complete the treatment, and then that progressed to a pelvic inflammatory disease right there. Okay, and then this is another use of ultrasound is pregnancy. And then in here we see the head. The first arrow is the head. The second arrow is the spine, the baby's spine. The third arrow is going to be the belly. The fourth arrow is going to be the femur in the baby. So this is the femur right there. So very important for pregnancy. Now, the next one, how we can use ultrasound is to detect gestational age, which is measuring the crown-rump length. Is from the head to the butt, pretty much, the crown-rump length, and that is the most accurate form to detect gestational age. Okay, and then in an ectopic pregnancy, this is what it looks like sometimes, and here we see the uterus, and this is the endometrial lining right here, which is this echogenic line, and then we see the embryo, which has been implanted outside of the uterus. This dash arrow is pointing to the embryo. Now, this kind of demonstrates that the embryo is outside of the uterus. However, this is important. However, most ectopic pregnancy are diagnosed by not visualizing the embryo in the uterus. So in this case, we caught the embryo outside of the uterus, but sometimes if we don't see it, if we know by the beta ECG that the patient is pregnant, and we do an ultrasound and we don't see any embryo implanted in the uterus, by definition, that is an ectopic pregnancy, even if we don't find the embryo, even if we don't find it, but we know that because of the beta ECG, the patient is pregnant, then that qualifies for an ectopic pregnancy. And again, this is depending on the hemodynamic stability of the patient, then we can do medical management, misoprostol or methotrexate, or surgical management if the patient is like blood pressure dropping, if the patient is hypotensive, all those things is surgical management. Oh, yeah, yes, surgical management. Yep. So this one is anencephaly. That's another things that we can see on ultrasound for babies with that fail to develop the brain in the 4 to 6 weeks of development. Now, in this one, this is a busy slide, but I just want to show you how important is ultrasound. Ultrasound in the hands of a experienced sonographer, I think, is a powerful tool. So these are many of the abnormalities that you can diagnose in uterus, in the central nervous system, skeletal, GI, GU, cardiac. So you can really go deep into ultrasound. It's a very powerful tool. So the next one is molar pregnancy. This is a pregnant patient that with an extremely high beta ECG, usually above 100,000, and it may present with early preeclampsia or this theca lutein cyst, this hyperemesis gravidarum. These are all like association with molar pregnancy. Usually the presentation of molar pregnancy is a woman who is pregnant, but their uterus is way too big for their gestational age. And if you throw in there the beta ECG greater than 100,000, if you throw in there that she has been nausea, vomiting with vital instabilities like hyperemesis gravidarum, where the electrolyte abnormalities, that is a molar pregnancy. Now, the next one, we're just gonna catch all for ultrasound, vascular, pediatrics, and point of care. So for the ultrasound, we got the B mode, I explained before, and the Doppler together, they call duplex sonography. And then they display the flow, direction, and velocity. And in the next slide, I'm gonna explain color Doppler and spectral ultrasound. So the first, let's establish some conventions. So this is a splenic artery. So if the blood flow is flowing toward the transducer, it is red. It is flowing away from the transducer, it is blue. It has nothing to do with oxygenation. I know a lot of books display red and blue with oxygenation, but this has nothing to do with ultrasound. If it flows toward the transducer, it's red. Away from the transducer, it is blue. That's the blood. Now in this one, this is the color Doppler, and then below we see the spectral, because it's on a spectrum. In the y-axis, we have the velocity. In the x-axis, we have time. And this is what happened in the liver. So the liver is a low resistance area, and blood always flow toward the liver. For example, in this one, we see all red, means that the blood is always flowing toward the liver. And then the velocity is above the baseline, meaning that the blood is always flowing toward the liver in a normal patient. Now, on the right, we see an image with a cirrhotic patient with portal hypertension. And we see that there is blue here, meaning that the blood is kind of backing up away from the liver. And then the blood flow, we see it below the baseline. Okay, and this is how Doppler works. If you've been in a car and there is like a police or like an ambulance approaching you, you're gonna feel like the sound coming like faster and faster toward you. And when the ambulance is like going away, then it kind of there is low frequency. And the same thing's happening in Doppler with the ultrasound. And in the next slide, here we have, for example, a normal common femoral artery. Usually femoral arteries are high resistance vessels, meaning that when you are at rest, the femoral arteries are constricted, and when you exercise, the femoral arteries kind of like open up to get more blood flow to the muscles. So here we have the ultrasound. If it's above the baseline, the blood flow toward the feet, and then below, during systole, the blood is flowing toward the feet, which is at these spikes. And then during diastole, when the patient is at rest in diastole, the blood returns in the femoral artery, like in the reverse direction, and that's normal. Now, let's see what happened when you have a narrowed superficial femoral artery. And just imagine kind of like when playing with as a kid with kind of like a hose, like a garden hose, and the tip, if you narrow it, then it's going to shoot even faster. And that's what happened here. So in the spectral Doppler, we see that everything is above the baseline in the femoral artery. And look at this is meters per second. So this is almost a 500 meters per second. Whereas in this one is centimeters per second. So the velocity increases much more. And usually for people who have peripheral arterial disease, this is where this comes in handy. That's why ultrasound can detect this, because you can actually detect even where the narrowing is, because if you're moving the Doppler a little more, when you get closer to the narrowing, the blood flow is gonna be very high. And that's how and also you can see it in the image. When you get close to the narrowing, the blood flow is high, the spectral velocity is going to be high, but also you will see the narrowing in ultrasound. So 2 ways right there. And then the biggest risk factor for exam, this is super high yield, the biggest risk factor for peripheral artery disease, smoking. Okay. And then pseudoaneurysms. So these ones, pseudoaneurysms, usually happen when someone undergoes like cardiac catheterization in the femoral artery. Sometimes the intima and the media break, but then the adventitia doesn't. And this allows for blood to extravasate, but still be contained. the blood extravasate, but it still is contained. And when what you get is a bulging pulsatile mass and systolic bruit. And then when you get this duplex ultrasound, you see red and blue, meaning that the blood is going into the aneurysm and getting out of the aneurysm, into the aneurysm, getting out of the aneurysm. And we can kind of see as well in the spectral, we see above the baseline, meaning the blood is going into the aneurysm, and below the baseline, blood is coming away from out of the aneurysm, out of the pseudoaneurysm. And again, the presentation for this is someone who underwent a cardiac catheterization, and now when the physician in the office can palpate along the femoral, in the thigh, along the femoral artery, like a bulging pulsatile mass. That is a pseudoaneurysm. Okay. And then the next one, DVT. This is how ultrasound can be diagnosed in DVT. Usually, or not usually, but in general, veins are they're like a blood reservoir, and they're easily compressible. So normally, when you compress using the ultrasound probe, the vein should collapse, as we can see here. In A, there is no compression. In B, we compress using the ultrasound probe, and the vein disappears. The artery are muscular, in a sense, like the media of the arteries, because they have multiple layers, they don't compress. So that's how we know if we are in the presence of a vein or an artery. Now, how this is important for a DVT? Well, in this image on the right, we have like a thrombus. And here we have like a no compression in the left. And then when you try to compress it, still the vein does not compress. And we can kind of see here this kind of like hypoechoic at the top of the vessel. This indicates a thrombus, and it is abnormal, a DVT. Okay, moving on. So here, this is the uses of ultrasound in pediatrics. So this is for germinal matrix hemorrhage, usually kids who are premature, low birth weight. They have been in formula feed, and they're very preemie babies. And this is like the clinical presentation. Preemie babies who have altered mental status, hypotension, bulging fontanelle, seizure, coma. That is a germinal matrix hemorrhage. And the way we see it, this is normal, what it should look like. This is the caudate, C for caudate nucleus, and T for thalamus. And this is the germinal matrix. When there is hemorrhage in a preemie baby, then you get this white echogenic or hyperechoic region. And the reason we can see in ultrasound inside the head is because the baby fontanelle, the baby's brain hasn't calcified yet, and the fontanelles allows like a window into the brain, as we can see in this image. There is this the fontanelle over here, and the echoes go through there and come back, and we can get kind of like a glance without using ionizing radiation into the baby's brain. Okay, developmental dysplasia of the hip. So the reason we can detect this in ultrasound, first of all, the presentation for this, usually risk factor, firstborn female, positive family history, maybe someone in the family has had this in the hip, less than 2 years old, does not want to walk. That's how the clinical presentation. And you're gonna see, they might describe the Ortolani and Barlow maneuver. This, you hear like a click or a clunk when the physician is examining the hip. You may see asymmetrical creases, or you may also see kind of like the thighs when they put together, they don't align. So these are exams, physical exams for developmental dysplasia of the hip. In ultrasound, what we're trying to do is we see this ilium. So the line, the green line indicates the ilium, and then the red line indicates the acetabulum. The angle between the two of them is the alpha angle, and normal should be above 55 degrees. So if it's below 55, that is the diagnosis for DDH.
So in DDH, if it's below 4 months of age, usually the way it presents in exam is, maybe you have this first-time born female who doesn't want to. It's like when the parents pick her up, she always like try to cover the hip, and then if it's below 4 months, then the right answer is going to be ultrasound, because the acetabulum and the bones hasn't yet calcified, so you can actually see it on ultrasound. Now, if it's above 4 months of age, then we'll do X-ray. This is very, very high yield for exam. Okay, and then necrotizing enterocolitis. Ultrasound is not the first choice for necrotizing enterocolitis, it's X-ray, but we can also see it in ultrasound. So in ultrasound, necrotizing enterocolitis is this white hyperechoic kind of like lines, and that indicates air. And usually the clinical presentation for this would be like a preemie low birth infant who started having bloody stools, bilious MSS, doesn't want to eat, refuses any feeding, and in the refuses feeding, bloody stool, bloody MSS, preemie low birth weight, and necrotizing enterocolitis. And in X-ray, you're going to see pneumobilia, so air in the biliary system, and second, pneumatosis intestinalis, air in the intestine. That is and this is a surgical emergency. These are diagnoses. Okay, now the next one, intussusception. So for this one, so in this image over here, we see that the bowel telescope in the direction of the dotted white arrow right here. And here, this is the cartoon. We see that one bowel telescope into another one. And the reason for that is that we have some of what is called a pathological point. So people who have the rotavirus vaccine, that is very weird, but very high yield. People who get the rotavirus vaccine are prone to getting intussusception. And in fact, people who have had any history of intussusception should not get the rotavirus vaccine. That's one. Two, another pathological point to get intussusception will be Meckel's diverticulum, celiac disease, Hinoch-Schlein purpura, or HSP. So anyone with a history of those diagnoses that are mentioned are at an increased risk of intussusception. Now, and as I mentioned before, someone with intussusception should never get the rotavirus vaccine. High yield for exams. Now, in the transfer view, we see a target or donut sign. This is what we usually, if they ever describe it to you in exam, they will say the target or donut sign or describe it. And then in the transverse view, this is what some people don't realize when they describe it this way. The bowel, what they're describing is this hypoechoic bowel that kind of surrounds the other one, kind of like it's eating the other bowel. And the sign is a pseudo kidney sign, because remember when I showed you the kidney before, it kind of looks like a kidney with the renal sinus in the middle, which has to be hyperechoic because of the fat, and then the parenchyma of the kidney was hypoechoic, so that's why it's called a pseudo kidney sign. And then for intussusception, the medical management, the management for intussusception is air enema or water enema. Air enema or water enema. Okay, and usually the complication for this, because sometimes the exams are the MBME exams like, this patient who presents with colicky abdominal pain, current jelly, bloody stools, he gets enema and then start like having hypotension, kind of get progressively worse, then that's because the enema or the air enema actually ruptured the bowel. That can happen. So one of the complications of treatment for intussusception using air enema would be like rupture, like a rupture or perforation, because you're kind of like putting air or gastrographic enema or water into it. Okay. And then the next one is hypertrophic pyloric stenosis. This is the child less than, clinical presentation first, less than 8 months old, who have projectile vomiting, non-bilious projectile vomiting. When you palpate in the abdomen, have this palpable olive mass, and in the mid-epigastric region, and what you're palpating is the pyloric stenosis. If it's greater than 3 millimeters wide, or the pyloric channel is greater than 15 millimeters in length, then that qualifies for pyloric stenosis. Now, these kids usually, first of all, in the MBME, they try to confuse you with GERD, because kids usually speed up food, like physiologic GERD, but what points you to hypertrophic pyloric stenosis is that the kid is gonna have electrolyte abnormalities. If you look at the sodium, potassium, they're gonna have a hypokalemic, hypochloremic metabolic alkalosis. And before going to surgery, they're gonna say, what is the next best step in management? And the answer is fix the electrolyte first and then go to surgery. Fix the electrolyte first and then go to surgery. Okay, so moving on here. Other uses of ultrasound is to detect blood or fluid in the peritoneum, and usually when someone is in a trauma and there is blood in the abdomen, the most common regions are the dependent portions, like the Morin pouch, which is this one that I'm showing right here in the left image. Then rectouterine pouch, this is the most dependent place of the abdomen in females, and then the rectovaginal pouch in men. Okay, and then here we see an image with pleural effusion, and here we see pleural effusion. This is the liver, this is the kidney, and then this is pleural fluid between the two of them. And this is the most common dependent region in the right upper quadrant, in the right upper quadrant. And then this is in the right image, we see a pleural effusion and ascites. We see a lot of ascites here. This is the diaphragm. Okay, and then pneumothorax. So for how can ultrasound be used for pneumothorax? First, when someone is normal, doesn't have a pneumothorax, we see that there is motion of the lung pleura, as we can see in this image. However, someone who is with a pneumothorax, pretty much the lung pleura does not move. And I actually got to see this in the ICU, in CICU. Like a patient was dropping the oxygen significantly. I was in my pulmonary rotation, and the oxygen was dropping, and the attending brought an ultrasound quickly, because even though X-ray can be done, sometimes ultrasound is much better for these quick cases. So this is and this is what the attending was looking for. Whether or not there is a motion of the lung pleura, that would tell you if there is a pneumothorax. Now, the next one is a pericardial effusion, which, as we can see here, there is effusion around the heart. And for this, the cardiac tamponade, that's one of the diagnoses that they like to test on exam. The muffled heart sounds, the electrical alternance. And the reason you see the electrical alternance is because kind of the heart is dancing within a fluid. And you see a low electrical voltage. That's because the signal dampens through the fluid. Okay, and then for this treatment for this would be like a pericardial effusion, a pericardial window to kind of remove that fluid. Okay, and then ultrasound can also be used for the central venous pressure, to detect central venous pressure. Normally, the IVC is 2 centimeters throughout the respiratory cycle. And then if the IVC diameter is greater than 2 centimeters throughout the respiratory cycle, but collapses less than 50% at end of inspiration, then that is elevated CVP. In contrast, if the IVC is less than 2 centimeters throughout the respiratory cycle, but collapses more than 50%, then that is decreased central venous pressure. And one of the clinical presentation for elevated CVP would be right heart strain, pulmonary embolism, like severe mitral stenosis because the blood is backing up. What else? Cirrhosis could be another one due to portal hypertension, the blood backs up. Now, decreased central venous pressure, the clinical presentation would be shock or hypovolemia for someone in a trauma. They're losing a lot of blood, and if you have an ultrasound, like I said before, an ultrasound in the hands of a sonographer is a powerful tool, an experienced sonographer. Okay, ultrasound can also be used for ocular trauma. So in here we can see the lens, which is what is showing this arrow, the lens. This asterisk is showing the anterior vitreous chamber. So the anterior chamber, and then the star is showing the lens, and then these arrows, dash arrows, they're showing the ciliary muscles. This is the vitreous chamber, and this is the retina. And this black arrow is showing over here the optic disc, the optic nerve is showing the optic nerve. And what's interesting is like if someone undergoes an ocular trauma when you cannot use the normal tools to look in the eye, you can, with the eye closed, you can put the do ocular ultrasound with the eyes closed. Very, very amazing. That's everything, guys. Most of my references were learning radiology. 5th edition, amazing book. And this is core radiology for radiology residents. Great, great book.